Good day to our lecturer and fellow friends. Today, Group 4 from the Dpns 2025 program will be presenting on a key topic in cardiovascular pharmacology, antiplatelets. In this presentation, we will cover several key areas: what antiplatelet medications are, the role of platelets in our body, and common examples of antiplatelet drugs used in healthcare settings. So, what are antiplatelet medications? Antiplatelets are a type of blood-thinning medication. They work by preventing blood cells, specifically platelets, from sticking together and forming blood clots inside blood vessels, which reduces the risk of stroke or heart attacks. Among the most common oral antiplatelet drugs used in hospitals are aspirin and clopidogrel. Other oral antiplatelet agents include ticagrelor, dipyridamole, and prasugrel. When it comes to injectable antiplatelets, examples include cangrelor and eptifibatide. Two additional IV injectable agents are abciximab and tirafibon hydrochloride. Next, let's look at the classification of antiplatelets. The first class is cyclooxygenase inhibitors. The main agent here is aspirin. It irreversibly inhibits the COX-1 enzyme, which blocks the synthesis of thromboxane A2, a major stimulus for platelet aggregation. It is administered orally. The second class is ADP P2Y12 receptor antagonists. These drugs block ADP from binding to P2Y12 receptors on the platelet surface. Under the thienopyridine subclass, which binds irreversibly, we have clopidogrel, prasugrel, and ticlopidine. Meanwhile, under the non-thienopyridine subclass, which binds reversibly, we have ticagrelor and cangrelor. The third class is glycoprotein IIB3A receptor inhibitors. These are potent agents that block the final common pathway of platelet aggregation by preventing fibrinogen binding. Examples include abciximab, eptifibatide, and tirafibon, all administered exclusively via 4 infusion. The fourth class consists of phosphodiesterase inhibitors and adenosine reuptake inhibitors. These drugs increase intracellular CAMP levels to inhibit platelet aggregation and promote vasodilation. Examples are celestazol and dipyridamole. The fifth class is PAR1 antagonists, with vorapaxar as the primary example. It works by blocking PAR1, the main thrombin receptor on human platelets. To summarize the mechanisms of action, aspirin permanently inhibits COX-1 for the lifespan of the platelet. P2Y12 antagonists, like clopidogrel and ticagrelor, block ADP receptors to halt the platelet activation phase. GPIIB-IIIA inhibitors directly block fibrinogen binding via 4 administration. PDE inhibitors reduce intracellular calcium to prevent platelet activation, while PAR1 antagonists block thrombin-induced aggregation. Why do we use antiplatelet drugs? They are used to prevent platelets from clumping in high-pressure vessels like arteries. Since arterial clots are rich in platelets, antiplatelets serve as the first line of defense against heart attacks, strokes, and peripheral arterial disease. Now, let's look at potential side effects. For aspirin, common side effects include dyspepsia, nausea, heartburn, GI irritation, ulcers, GI bleeding, and tinnitus at higher doses. For ADP antagonists, clopidogrel can cause headaches and bruising. Ticlopidine may cause diarrhea, rash, and bruising, while prasugrel can cause nausea and skin rash. For ticagrelor and cangrelor, key side effects to monitor include shortness of breath and headaches. For GPIIB-IIA inhibitors, abciximab can cause nausea and hypotension. Eptifibatide can cause bleeding at injection sites and thrombocytopenia, while tirafibon may cause nausea and dizziness. In general, antiplatelet therapy is contraindicated or requires extreme caution in patients with active bleeding or bleeding disorders, history of intracranial hemorrhage, active peptic ulcer disease, or known hypersensitivity to the drug. Specifically, prasugrel is strictly contraindicated in patients with a history of stroke or TIA. Ticagrelor should be avoided if there is a history of intracranial bleeding. Clopidogrel requires caution in active bleeding or active peptic ulcers. As nurses, what are our key responsibilities? First, always practice the 7 rights of medication administration: right patient, right medication, right dose, right route, right time, right to refuse, and right documentation. Second, Conduct thorough baseline assessments. Check vital signs. Assess for symptoms like chest pain, dizziness, or dyspnea, and monitor lab values like renal and liver function tests. Third, monitor therapeutic efficacy. Ensure blood pressure and heart rate remain within target ranges. Assess for relief of chest pain, and check for signs of heart failure such as edema. Fourth, monitor for adverse effects such as hypotension, bradycardia, tachycardia, dizziness, headache, fatigue, or allergic reactions like rash and respiratory distress. Fifth, provide comprehensive patient education. Advise patients to take medications strictly as prescribed and not to stop abruptly. Instruct them to avoid alcohol and unapproved supplements, and encourage lifestyle changes like a low-sodium diet and smoking cessation. Regarding routes of administration, the oral route is most common for long-term therapy and chronic management, absorbing through the GI tract. Examples: aspirin, clopidogrel, ticagrelor, and prasugrel. The intravenous route provides immediate onset and is used during acute emergencies or procedures like PCI. Examples: cangrelor, apixaban, eptifabadade, and tirofiban. The patch route delivers continuous transdermal absorption into the bloodstream, such as nitroglycerin patches used for adjunctive cardiovascular support. Lastly, the intramuscular route is rarely used for primary cardiovascular drugs due to variable absorption, reserved only when 4-access is delayed in emergencies. That concludes our group's presentation. Thank you very much for your time and attention. We are now open to any questions you may have.